Hi, my name is Pamela Torres, and I'm going to talk about adjuvant selective in high-risk renal cell carcinoma after nephrectomy. Definition: Sunitinib, a vascular endothelial growth factor pathway inhibitor, is an effective treatment for metastatic renal cell carcinoma. It was treated to determine the efficacy and safety of Sunitinib in patients with locoregional renal cell carcinoma at high risk for tumor recurrence after nephrectomy. Applications in medicine. Sunitinib-treated patients had significantly lower scores for health-related quality of life than those in the placebo group while they were receiving active treatment. Patients with locoregional renal cell carcinoma are at high risk for tumor recurrence after nephrectomy who were receiving adjuvant treatment with sunitinib had a longer duration of disease-free survival than those receiving placebo.
The most compelling data are the S-track study showing a disease-free survival advantage for sunitinib. We have to take those results with a grain of salt because there are other studies that do not show an advantage. And there are some real quality of life issues with sunitinib treatment compared to placebo. So it's not a slam dunk, but it is compelling and interesting. And something that we can pull out in people who are motivated to, prevent recurrence. So far, we don't have any home runs in the immuno-oncology space either for adjuvant therapy, but there may be more to come on that as studies mature.
Pros and cons. Pros: Mean duration of disease-free survival was 6.8 years in the sunitinib group and 5.6 years. At 3 years, the proportion of patients who were disease-free were 64.9% in the sunitinib group. Cons: At the time of data cutoff, an event of disease recurrence, a second cancer, or death had occurred in 113 of 309 patients in the sunitinib group. The most common all-cause adverse events in the sunitinib group were diarrhea, palmar plantar erythrodysesthesia, hypertension, fatigue, and nausea.
Hi, my name is Dan Petrolak. I'm professor of urology and medicine at the Milo Cancer Center at Yale University. I talked today about the controversies in renal cell carcinoma, and we divided the talk into two different sections. First was the use of adjuvant TKIs in patients who have had high-risk renal cell carcinoma after surgery. And what we concluded was the fact that these drugs have toxicity issues. There are no trials that have shown a survival benefit for either sunitinib, pazopanib, or sorafenib in this particular setting. So I think that what we need are better ways to define which patients should use these drugs. Should it be high risk, although the studies have shown no benefit for the high risk patients. And I think that importantly, sunitinib has been approved in this particular line of therapy. I think it's important that the physician have an informed discussion with the patient regarding the appropriateness of administering these drugs. The second portion of the talk was reviewing a recent study from the New England Journal of Medicine where patients were randomized to receive either sunitinib alone or sunitinib plus nephrectomy. And in contrast to data that Dr. Bob Flanagan presented a number of years ago when patients with metastatic disease were treated with interferon or interferon plus nephrectomy, there was an improvement in survival for those patients who received sunitinib alone. Now the question is whether this is applicable to all patients. The patients who had the best outcomes were those patients who were poor risk or intermediate risk. The question is whether this is applicable to those patients who are good risk, and we really don't know. The second question is, does this apply to immune therapy? We really don't have any good studies that have looked at nephrectomy prior to immune therapy for patients with metastatic disease. So I think there are some very, very important clinical questions that need to be asked based upon this data. And at this particular point, I think you need to have a discussion with the poor risk patients and the intermediate risk patients whether they should receive a nephrectomy if they're undergoing TKI therapy.
Issue applied in Ecuador. Each year, approximately 300,000 persons worldwide are diagnosed with renal cell carcinoma, resulting in 129,000 deaths. The 5-year survival rate is 53% for local regional disease and 8% for metastatic disease. In Ecuador, the most common carcinoma in the different subtypes of cancer is renal clear cell.
STRAC is the adjuvant randomized phase 3 study comparing sunitinib with placebo in high-risk individuals with renal cancer who have had a nephrectomy and in surveillance and follow-up. It's an adjuvant study. You get a year of sunitinib at 50 milligrams standard doses, and it's against placebo. And the trial shows a significant progression-free survival advantage statistically, with a hazard ratio of 0.76. The central review and the independent review are different from each other. The central review and the clinician's review, they're different in the results. One's significant and one's not significant. But essentially, the hazard ratios are 0.76 and 0.81, which are in the same ballpark as one another. And what that shows us is the results are marginal from statistical significance. One's just one side and one just the other side of significance. And that's really important. And there's no survival advantage in this study. The hazard ratio is 1.0. And that means we're not curing patients. Now, some people say that might be a bit early, but we've got a previous trial with Assure, similar design, which also didn't show, this one didn't show any progression-free survival advantage, and also didn't show a survival advantage. And essentially what this is showing us is that while we're showing signals that may or may not be promising for progression-free survival, we're not seeing anything in overall survival. And patients obviously want overall survival. That's the goal of this, because in the adjuvant setting, we are going to over-treat a group of patients who don't relapse. And so therefore, what I would like to see before I start recommending adjuvant therapy is I'd like to see either a positive progression-free survival meta-analysis, so we can confidently say you can delay the time of the cancer to come back, number one, future trials that are positive, or an overall survival signal starting. And one of the issues in the way I look at that is that if we had a small difference, a trend towards a survival signal, that would be promising and would suggest there's a relationship between the two of progression-free and overall survival. But because there's currently no relationship, it suggests to me that all we may be doing is just delaying progression-free survival, but not actually helping patients cure their cancer.
Conclusion. Up to 40% of patients with local regional renal cell carcinoma have a relapse with metastasis after nephrectomy. However, since the life expectancy after nephrectomy in this population of patients is nearly 40% at 10 years, further study is needed to confirm whether the effects of adjuvant sunitinib treatment is maintained in the long term. Thank you.